dentist with over a decade of clinical experience. She has worked with her mentor, Dr. Suhas Lele, on various pageants, celebrities, and top models. She is the smile care expert for Miss and Miss Personality in Pune. She has received various awards, including the Aesthetic Practice of the Year 2024 by Famden Excellence in Dentistry, Outstanding Dentist of the Year by Famden Excellence in Dentistry 2022, and Aesthetic Dentist of the Year 2022 by Indian Dental Divas Award. She currently maintains her private practice at Pune, where she tries to marry aesthetics and functionality to deliver healthy smiles to her patients. She is an accredited member of IAACD. She is the mentor of Sanah Sayed Dentistry and regularly conducts workshops on smile designing and composites. She has trained over 3,300 dentists pan-India so far. She regularly contributes to various magazines of national and Southeast Asian dental magazines like The Dental Practice and our very own Aesthetic Expressions by IAACD. Her work has also been featured in various other dental magazines by Palmer Group Canada. Welcome, Dr. Sanah Sayed. Over to you.
Thank you so much, Dr. Trishla. I'm really stoked to be here, very honestly. I am very thankful and grateful to Dr. Amit, Dr. Harsh, Dr. Nikhil, Dr. Trishla for having me on board today. And to everybody who's attending, the 42 participants that I see over here, to taking time off because I know it's a working day. We have only 1 hour to cover this topic, which honestly cannot be covered in an hour, but I will do my very best. So let me start with sharing my screen. We will be taking some Q&As in the end. If you have any questions, we can address them that time. Can you all see my screen?
Yeah, Dr. Sanah, yes.
Okay, so let's start. Now, I really truly believe that your eyes cannot see something that your mind does not know. So, for aesthetic dentistry, whenever you start working on cases like that, you should know what looks good and what does not look good. So, my image on the left, my eye is quite in balance and it's looking like a very harmonious picture, as opposed to my picture on the right, where my eye is drawn more towards off center because the force is acting in such a way that my eye is drawn towards the area where there is maximum force of attraction happening. How do I balance this? This is the way I put an equal and opposite force so as to not cause my eye to be drawn in one side. And this is called visual distress. Why is this important to me? Because this is how it is translated for us in dentistry. Not just dentists, not just aesthetic dentists. Though I'll agree and I'll admit that my favorite time pass sitting on airports is to look at people's smiles and teeth and to think how I'm going to actually make them better. But even for a layman, when they see smiles like that, when they see teeth like that, which are discolored, which have a midline diastema, which have got a chipped tooth or a fractured filling, they are not going to make eye contact with the patient. They are going to rather start seeing their teeth. And that's when we need to step in, not by making it look fake, but by bringing harmony to their smile so that they start having those conversations by looking at the patient's eyes. I'm not going to, by the end of this session, show you how to take swoon-worthy Instagram posts and, like posts on Facebook, which will get you hundreds of likes. But I want you to learn clinical day in and day out dentistry that is going to get you more patients through referrals, because if you are able to master this particular treatment modality, which is a class 4 build up for a patient who has some social function coming up or who has come to you from trauma, you've won. And he's going to send a lot of patients to you. I'm sure about that. Now, why are we considering why are we considering composite for doing these kind of restorations? Because of this one particular article, which was published in 2002 by Edelhoff, which says what? It says that if you have a case where there is a chipped tooth, what is the treatment modality that you are going to take up, which is going to prevent maximum loss of tooth structure? Meaning, what is going to be the most minimally invasive? So in that case scenario, composites top the list, wherein you're losing only about 3% of your tooth structure as compared to a indirect veneer also, which is about 30%, and crown is 63 to 72%. So now we imagine a scenario wherein you have a relative, or God forbid you've fallen and you have a chip. What are you going to do? You're not going to want someone to put a crown on that tooth because it's easy to do, right? It's easy to do because we see this year after year. days after day in our clinical practice, it's easier to put something indirect because the hard work, the laborious job has been done by the ceramist. But this is something which is highly skill sensitive. So we all know this. This is like common sense that I'm going to do a treatment modality which is going to be versatile, which is going to be repairable. Chair side ease is there, but it is complex. So the complexity of things, there are a lot of steps that you need to bypass in order to get that picture perfect looking restoration. Also, in my opinion, a syringe of composite is something that really humbles you down. If you know the meaning of the word mojo, there can be a day wherein you've done your best and your tooth is looking like the neighboring tooth, but there can be a day also, which can be the very next day, where you just cannot mimic that neighboring tooth. It is a very challenging thing to do. And this composite, though it is taught early on to us, starting from third year, I think we are all introduced to composites. But in my opinion, and also according to an Australian survey, this is one of the most complex things to do. But we must put our heart and minds into it. So I'm going to hopefully try and make this predictable for y'all by giving y'all a roadmap with 5 pit stops, with the first being bevels. Okay, what's a bevel? Bevel is nothing but it is a slope for, or it can be a horizontal slope from an edge. Now we just spoke about minimally invasive dentistry, and you will say that I'm asking you to create a bevel. See, in this case scenario, the bevel is very, very important. If you don't do this, you're going to have a demarcation line, or you're going to have that white line which is kind of going to show up. So we need this bevel in order to ensure that there is a blending which happens between your composite restoration and the tooth. And there are 3 types of bevels. Not all case scenarios will warrant a very large bevel. Most of the times what we are using is a medium bevel. And there's also something called a small bevel. The small bevel is only if your chip is placed in the incisal area. The medium bevel is about a 45-degree bevel, which is about 2 millimeters away from your chipped area. And this is the most commonly used scenario wherein you're losing dentine as well as you're losing your enamel. Large, very rarely it is to be used. Maybe in cases of direct veneers, or you're doing a very, very large restoration, in that case scenario you would consider doing a large bevel which is about a 55-degree, and it would be about at least 3 or 4 millimeters away from the chipped area. But most commonly what we are using is a medium bevel. Now, if I have to represent this pictographically, then my red is my fracture line. The orange that you see is my bevel, which I've created with a red ring tapered fissure burr. I usually use a money burr, which is a red ring taper fissure rounded 13F, TR13F. But we should always polish this bevel in order to convert it to an infinity bevel. I usually use the 3M, the courses, the dark red ring, in order to transfer this bevel which I used with a burr to make it like an infinity bevel with the disc. And I always over etch. Now, what is my thought process for over etching with 37% phosphoric acid? See, even if we use a microscope, or like I use loops, it's impossible for us to actually see where that composite is ending. It can be a very thin section of composite when you're blending it with a modeling resin, or that composite, and you really don't want that to end at a non-bonded surface. You want it to be on a bonded surface. The other thing is that even if you etch with 37% phosphoric acid, in 24 to 48 hours, that area is going to remineralize. So it's not like you're damaging the tooth structure by doing this. It's just that you're being cautious. You don't want any area to be on a non-bonded surface. So this is what I use. If you're using a 3M, then I use the red one. If you're using a shofu, then I use the black one. And that's how I make that an infinity bevel. Okay, this is a short video that I'll play for y'all. So imagine that this is a fracture. Because you're starting off, then you can use a pencil, and roughly it's about 2 millimeters. Here, for the ease of showing, I have used a micromotor with a burr converter, but of course you have to use water in a drill, in an air rotor. So look at the angulation of the burr. It's about 45 degrees angulation, and that's how you'll remove the tooth structure from there. It's not like a starburst appearance, or having varying degrees of depth and all of that. It can be at one depth only. You don't need to do anything very, very fancy. But once you're done with this burr, then you have to transfer it into an infinity bevel by using that disc. So once you're happy with using the burr, you're going to use a disc. And in the same motion, you're going to go ahead. The speed of the disc, generally speaking, all finishing discs, I use around 10 to 12,000 rpm, because this is something you generally don't use water with. You want to see where you're going. Those are the critical areas where your composite is going to come sit and your tooth structure is there. So you don't want to over prepare anything. So that's bevel. Now let's talk about material science. I'm not going to go very deep into this because I've been told that this is something that people don't enjoy listening to. So something which is very superficially and on the periphery I'm going to touch is that we all know about the evolution of composites. It started from a macrofilled and now we are at nanofilled and nano hybrids. But majority of the articles that you have read, in fact all of them say that with nanofillers, because you have more of your filler content in a volume of composite, you're going to have better mechanical properties. By mechanical properties I mean you're going to have better compressive strength, you're going to have a very good fracture toughness. What that means is that your front teeth especially, they undergo a lot of tensile forces. So more than these kind of pounding forces which you get at the back, in the fronts you get a lot of these bending forces. So your composite has to be resistant, or it should kind of withstand these kind of bending forces before it gives way. So in my opinion this is very important, and because you're working on the front tooth, it should have a very good finishing and polishing. And it's not something that you should struggle with and do 30-40 minutes of finishing and polishing. It should be like maybe 10 strokes and you're done. And it is also very important that this material over a period of time is able to retain this kind of finishing and polishing, and it maintains that kind of luster. If done well, composites can give you a very good life of, I would say, even 5 to 7 years. I've seen good cases, and towards the end of the presentation I'm going to show you a case that went on for 12 years. Okay, so nano hybrids in my opinion score here, like I told you. This is extremely important and very rarely does anyone explain about this or people know about this. So why are we layering in the front teeth especially? Why don't we just take a dentine shade and build a tooth dentine in to out? Why don't we just take like an enamel shade and we build a tooth from in to out that way? See, what we are trying to mimic the tooth, it's an extremely specialized structure. I mean, it's not that one area of the tooth is going to behave in one particular way. The areas of dentine, because they have got collagen, hydroxyapatite, organic, inorganic, there is a lot of mesh up that is happening there. Some areas are going to scatter light, some are going to diffuse light, some are going to absorb light, some are going to reflect light. So if we want to mimic that, especially if it's a patient who is young and the fracture is quite extensive, then we cannot rely upon just having one kind of opacity. We will have to layer. Okay. The second thing is that, especially in composites, and when we're talking about enamel composites, they are either transparent or translucent. And whenever you have these kind of materials that are two transparent or translucent objects that are stacked on one on top of the other, like this glass pieces, you're going to lose value. So you may very often see that you've selected the right kind of recipe, you did your composite button try-on, but the end result for you and for the patient looks like the tooth or the restoration is looking very gray. So why does that happen? That happens because you have placed too much of enamel in too much of thickness. Okay. So most composites fail when they're trying to mimic opacity of a natural tooth. While maintaining opacity, the composite cannot be translucent, and if it is translucent, it cannot be opaque. This is a property that is only specially found in a tooth, and composites are unfortunately not yet able to mimic this. Why does this happen? This is mainly because the refractive index of the composite is not the same as your enamel and dentine. Enamel has a refractive index of about 1.62 and dentine of about 1.54. Most of the composites that you find are in the range of 1.5 to 1.56. Only I know Myserium that is having a refractive index which is very close to enamel, but it is very expensive as far as I know, and it has not been launched in India. Okay. So the other thing is that if we try to do a natural layering protocol, by natural layering, what I mean is that whatever is the thickness of the dentine in a natural tooth and whatever is the thickness of enamel in a natural tooth, you're going to actually place that very thickness in composite also. If you try to do that, you're not going to achieve the same kind of finish because the refractive indices are not the same. So in order to overcome this and the glass effect, what has research proven or what have multiple clinicians found, that you need to place enamel composite only in a thickness of about half or one third of its natural thickness. Now, enamel in most cases is 1.5 millimeters. So if I take half or one third of that, that will roughly put me at 0.5. And this was the basis for us to find the anterior misura with style Italiano launched, wherein you're going to run the instrument across the bevel and create that much space for your enamel shade. So this is the understanding or the basis why anterior misura keeps an enamel space of only 0.5. It is due to the glass effect. Okay, I hope you all are with me. I can't see anybody, so I'm just running through my presentation. Okay. So, as per that, and as per the optical properties, let's divide our composites as out, mid, and in. By out, I mean my enamel shades, obviously, because it's out. By mid, I mean basically my body shades or universal shades, which are going to mimic my dentino enamel junction. And by in, I mean dentine. So, enamel is responsible for your value, luminosity, translucency, and of course, it's going to act like a shell, so it's going to alter the final appearance of the tooth. Dentino enamel junction is basically where all your characterizations are. So, say for example, you have a tooth which is highly characterized, which has got white spots, which has got a blue translucent area. You can never place enamel, and on top of it, you're going to kind of place your tints or whatever. The patient brushes is going to be off. Where is the right place to place all your tints? It's just after your body, or it is just under your enamel. Okay, so that enamel you're going to place in a thickness of 0.5. So all the characterizations that you have done, you're going to get those. And by opalescence, I mean the same thing, that it's going to appear blue in certain kinds of light, and it's going to appear orangish in certain kinds of lights, like you see in the sky. That is an optical phenomenon, not really that the tooth is blue or the tooth is orange. It just happens because light is falling on it in a particular way. Dentine. Dentine is for the opacity and for the chroma of the tooth. It is also for something we call fluorescence. What fluorescence mean is like the tooth has got an inner glow. It looks vital. Teeth which are alive as compared to teeth which are non-vital, they look, a bit different. That is because imagine your light hitting a tooth surface and then it being reflected back at a even higher speed. That is what happens during fluorescence. So the tooth looks more vital, and it is also contributing to the yellowish appearance of the tooth. Okay, now let's come to this highly miscommunicated sort of topic, where a lot of people get really worried, especially if it's in an anterior tooth. Now, see, for anybody who says white, white is white, but for us, white can mean, depending on what Vita shade guide you're using, either 16 colors or 29 colors. That is the world we live in. Okay, so we need to really specify what we are using. But the good thing is that in shade selection, I will tell you, most of the Indian population, I would say 90% of the population belongs to the A2 family. And even if there is a little bit of variation, there could be A3 or there could be A1. Usually, what I've seen in the last 15 years of my practice, I don't see a lot of other variation. So, if you have these three syringes with you of composite, you can almost do any case in your practice. And we all know this, that color is an optical phenomenon of light. It's not that some object is red in color or green in color or yellow in color. It is because that light gets reflected back and it is perceived by our eye in that particular way. Like I'm wearing black today, that is because all the light is getting absorbed and this is appearing black. Okay, so we know this is an optical phenomenon, and on basis of this, Albert Munsell divided color into three different things. He divided into hue, value, and chroma. And I'm telling you the two other important things which are there for us as dentists, which we must consider, is translucency and opalescence as well, in addition to all of this. Now, what is hue? Hue, very simply put, it is what color the object belongs to, or in our case, which family or which group the tooth belongs to. Like in a Vita shade guide, does the tooth belong to A, B, C, or D? Those four groups, which one it belongs to, that's your hue. Okay. What's chroma? Chroma is the degree of saturation, or how pure is the color. Meaning, if you have an A4, A4 will be a more saturated form of the A family as compared to A1, where it's going to be a more diluted version of that A family. And the most important for us, which should be the starting point of all of our dentistry, is value. Why? Because Even for laymen, people who are not even dentists, they can perceive value. Like your patient can come up, they would not know the difference between A1, A2, or A3. But if your restoration is looking gray, or because of decay, their tooth has turned gray, they are able to appreciate that, and they will tell you, Doc, ye aise दबा हुआ सा दिखता है that, it doesn't look like it's alive. They may not be able to explain it in terms of value, brightness, darkness, but they'll say probably that the tooth is looking gray, or the tooth is not looking like the rest of the teeth. They can appreciate value. That is because the rods outnumber the cones in our eye. Like for every cone there are 10 rods that are present in our eye, which is why we can appreciate the brightness or the dullness of a restoration really well. Okay. Now, all the composites which are commercially available, they are keyed to a Vita shade guide. Okay. But you will never find two different companies ka A2 or A3 looking the same. What if I tell you this is A3 from three different companies and they are all looking different? So, which brings me to the next thing. How do we select color, or how do we select shade in composites? We do it by a technique called the composite button technique, which was given by a Turkish dentist. Okay. As per this technique, you have to take a little roll of composite, place it onto the area that you intend to. You have to cure it, because many a times we feel that composite changes color after polymerization as well. And if it matches, then in that case, you're going to go for this particular shade. Now, where do we select what? You always will select the dentine shade at the cervical area of the tooth. Why? Because the enamel is thinnest in this area. You're going to always select the body shade or the universal shade in the middle part of the tooth, because here you have enough of enamel and dentine in the body area. So you're kind of midway between the two. And incisal will always give us the enamel shade, because this is the area, especially in young people, where it is devoid of dentine. Now you need to go back to your manufacturer and ask that what is the range of opacity across their nomenclature. Now certain companies, you will find that there are four nomenclatures. Like they'll have an opaque, I think 3M has this. They have an opaque, they have a dentine, they have body, and they have got enamel. In enamel also, they'll have a chromatic enamel and an achromatic enamel. What chromatic enamel means, that they are A3E, means a color attached to it is chromatic, it's with chroma. And their achromatic will be something which is like a CT, which does not have any color in it, it is completely translucent. So just for the sake of understanding, in this particular table, the composite that I have used, the dentine is a low translucency composite, which is in the range of 34 to 37. Then in the middle, the body that I've used is in the range of 43 to 51. This is like a medium translucency. And incisal enamel, it's like a high translucency, which can be even up to 64%. Now let us understand how this impacts us. Okay, you're going to select your U, value, and chroma. Like I told you, you're going to first select with value. So the picture number 2 that you see, that I have taken from my DSLR camera, and you need to do two things now to your picture. You first need to make it monochromatic. That means you're going to make it black and white. You can do this in any software. This is going to allow you to select the enamel. Why? Because enamel corresponds to the value of the tooth. And the second image that you see, that is my number 3, you're going to hyper saturate or over saturate that picture in order for you to select the dentine. That's the chroma. And this is how I have selected the blue ring that you see. I've selected the value in an enamel in picture number 1 basis what is blending the most. And in picture number 3, I've selected my body and my dentine, because that determines my chroma. Okay. Now, how does this impact us? I've done just a very small experiment in order to show across nomenclature how the opacity really affects us. Okay, so I have made composite discs which are around 0.5 millimeters in thickness. I've placed it on an IFU sheet which we all nicely throw. So I've put it to use. And after curing it, I've placed these discs on top of it and taken a photograph in order to understand how much of light passage it allows. So what you see, the OL, that is nothing but opaque light, that is dentine. Okay, so it is not allowing much light to pass. We can't really appreciate what has been written underneath it. Then you have a body shade, which is allowing some light to pass, and some of the light is probably getting reflected. So you can see something is written, but you're not very sure. So why is this important? If you have got a discolored stump we know that just building the tooth in body may not help. Okay, so we may have to put a dentine and then cover it up with a body, and then we may or may not choose to put an enamel depending upon the age and the case that we are dealing with. Then you see your enamel, which is clear opal, where you see the light is passing a little less as compared to CL, which is my clear translucent, where you can see the written matter a bit more. And the last one are the smart composites, which are now launched, which are nothing but chameleons. These are basically in thin sections, very translucent. This can be translucent to up to 64% of light that may pass through it. But in thicker sections, like I've done here, at zero point 0.5 millimeters, you can see what is written underneath it. At 1 millimeter, you may not be able to appreciate too much what is written, but at 3 millimeters, it's completely blocking. So remember what we spoke, that the composite is not able to maintain its opacity and maintain its value at the same time. But these composites now, with the newer research that is coming in, are able to do so. Of course, they also have certain limitations, and you need to understand where they need to be used and how they need to be used, but that's not within the scope of today's topic, so we won't talk about that. But what I'm trying to say is that there's constantly better materials that are coming in, and I think resin is the way. That's the future for us. Now, simply having the right recipe is not going to solve our problems. Why? Because imagine you and I are both making a halwa, and we all have the same ingredients, but my halwa can be sweeter than yours. Why? Because I can use more sugar than you, right? So, in the same way, I can also place my layers in different thicknesses, and our end result can be different. Okay, so if I have a slightly translucent looking restoration, that may be because there is too much enamel that I've placed, the problem that we discussed in the previous slides, or my dentine is simply not opaque enough. Okay, if my restoration is looking too opaque, maybe I have used too much of dentine, maybe I've used a very opaque dentine, or I have used too little enamel. But what is a cheat sheet? Cheat sheet nowadays is a universal or a body. If the restoration is not too large, or and especially in the case where you're doing a class 3 restoration or you're doing a diastema closure, say for example you start and end with a body, in most cases you're going to have the perfect finish, because opacity wise it's nearly there, you don't really have to layer too much. Okay, and this is the kind of end result you can get. These are multiple class 3 restorations done mesily and distally on all four incisors, and it was also extending in my incisal area. So if you do the right kind of layering with the right kind of understanding of opacity, whatever composite you use across any company, if you understand this opacity, you will know what to layer with what. Okay, so this is very, very important. Now there are multiple roads to lead you there when we are doing a class 4 restoration, but because we don't have enough time, I'm going to be only discussing two techniques with you all today. That is how do you make a silicone putty index, and what is a BRB technique. Okay, the last two. So I'm somebody who does not like things to be done at last minute. That's just my personality type. So I always prefer to have the patient, if it is a chip tooth, I take an impression and I get a wax up done. Either I do a wax up in expired composite, or I may send it to the laboratory to do a wax up. That's irrespective. Or if the patient has got no time, then I do this technique called the BRB technique, which does not mean be right back. It means that's the abbreviation for those three dentists from Brazil who have come up with this technique. So let's discuss about that. Now, if I want to make a silicone putty index, what are the things that I'm going to watch out for? First, I want to only create it in addition silicon. I don't want to use a condensation silicon. I don't find it very accurate. Second, it should form a good contrast, because even in thin sections, you should be able to see the composite. So it should not be a very dull color. It should be a bright colored, something that it creates a nice contrast. Third, it should not be something that is very flexible, and at the same time it should not be something that is very rigid. So how do you check this? Once it sets, which is about 4 minutes, right, you throw it onto the floor, and if it bounces back, that means that it is going to have a hardness of roughly 70 shores, and that is a good material for you to work with. Okay, you always make a homogeneous mix, you make it like a laddu, and you always place it into the palate area but never onto the teeth, and then with your your thumb pressure, with not excessive pressure, but some pressure. You're going to start extending it towards the buccal. Now, how much should you extend? Okay, I generally like to keep it as a rule of 4 is to 2. What that means is that I'm going to have a vertical height from my incisal edge of an intact tooth of, say, about 4 millimeters, and I'm going to have a buccal overlap of about 2 millimeters. And this is the most accurate way, even by certain books that you'll read and articles you'll go by with. This formula always works. Okay, now you will have some excess in the buckle, like I told you. So this is not the way to hold your blade. You should always hold the blade parallel to the putty index such that it is perpendicular to the incisal edge, the angle that I'm holding it at, and then you can remove your excesses, whatever is needed. Never have too much excess buccally, because then, especially if you're doing a highly characterized tooth and you're doing that halo, you may find that you've removed the entire putty index and you've built the tooth, and now it is looking longer than the tooth which is adjacent to it, in which case it's an absolute catastrophe, because then if you try to reduce that incisally, you're going to lose your halo. So that does not work. So you need to be very careful. Whatever changes are needed to be done in the palatal shell, you need to do it even before you start layering. So you keep an eye always on the adjacent tooth, and whatever changes are needed needs to be done at that time only, there and then. Now, many a times, especially if you're using a rubber dam, like I do all my bonding cases with rubber dam, you may feel that the putty index was sitting nicely without the rubber dam, but now after placing the rubber dam, there is some discrepancy. So why is that discrepancy? Why is that incisal edge hanging a bit more? It's because you have taken into consideration that area of the palate which is not needed. So whatever is the area that you do not require, which is going to sit against that rubber dam, because it also has a certain amount of thickness, just get rid of that. You don't need those areas any which ways. So you need to cut it in a scalloping manner like I have shown on the right. Okay, what is the next thing you're going to do? You're going to place it and verify that it has been placed absolutely correctly the way it was before you placed rubber dam. Then take a sharp instrument and the edge of the fracture you scribe with a very sharp instrument, knowing that this is where, or this is your Lakshman Rekha, and you're not going to cross that when you remove the putty index, and you're going to always place the composite outside the mouth rather than placing the putty index and then placing the material inside, because in that case you may get voids and it may not be very accurate. So you're going to always place composite outside the mouth, which is why you're scribing, in order to demarcate that boundary, that you're not going to extend beyond that. And many a times, if your composite is a bit rigid, it may not hold on to the palatal index. So in which case, what you do is just place some bonding agent. You may cure it. That will increase the wettability and it will make that surface more receptive to receiving the composite material. Now, what is the BRB? Whatever I have described so far, that is in case you have the time, your patient lives in the city, or your patient is coming for 2 to 3 days and you have some time. Now, many a times you will have that one patient on a Saturday evening who has a flight late night and is in the city for less than 24 hours. Okay, so what do you do in such a case? You're going to create a palatal putty index. You're going to take an impression directly in the mouth, either with your firm finger pressure, or you can do this even on a tray, and you're going to arbitrarily mark with a pencil that, okay, this is my rough outline, this is how my tooth is, and with a rounded red ring burr, you're going to actually remove that much. You can use some blade also, and in the end, you're going to just polish that area with a silicone point. So, what you see on the left, that is my BRB. What you see on the right, of course, which looks very very accurate, that is directly from a tooth, and it can be either from a direct indirect mock-up. But BRB is an arbitrary technique. I'm not saying that this replaces this technique, but this is a good standby option in cases where the case has come to you on a fly and you really cannot do much. So in terms of how accurate this is, direct from the tooth or tooth fragment and indirect mock-up is really up there, and the least accurate would be the BRB technique, but it's a good make do. You can still work with it. Now let's get into certain cases. Okay, now imagine that the patient is young, the patient has got a very characterized tooth, and it's a big fracture. So in which case scenario, you've lost dentine, you've lost enamel as well, and you need to replace everything. So how are you going to go about it? First, you are going to establish a palatal shell. The palatal shell, depending on how characterized the tooth is, you can do it in clear translucent, that's CT, which has got a nice bluish tint. It's available from 3M. Or if the tooth is not very characterized, then you can go with a flowable. Okay. Or if the patient is old, then you can go directly with a dentine shade, because they don't have very characterized teeth and their teeth start appearing more chromatic as they age. So imagine now in this case scenario, it's a young patient. What is the protocol you're going to follow? You will place dentine that is just below the bevel. Then you're going to place a universal or body in a mamelon fashion, assuming that the adjacent tooth has got mamelon pattern. But when you place it, it's not going to cover the bevel completely. It's going to be halfway somewhere at the bevel. And when you finally place the enamel, that is going to extend beyond your bevel. And in case the tooth has got a halo, by halo, what do I mean? There is like a whitish appearance which we see at the incisal edge. Again, it is not something that exists in the tooth, it is just an optical phenomenon. Okay, you see it because of the way the light is reflected, transmitted at an angle of 30 degrees and all that. I don't want to get into those details, but it is sometimes that you see it in a young patient. So, what you're going to use to kind of reproduce that, you can use an opaque shade or you can use a dentine shade. Usually what I do is, if my target shade is A2, if my tooth is A2, then I go for a shade lighter, so I may build my halo in A1. Or if I have a very constricted space, then I may not go with a dentine shade or an opaque shade. I may just use a white opaque tint. Tints are available from Coltine. You can go through those. Okay, it's not something which is used very regularly. Very rarely you're going to use that. So let us see one small video of the entire layering protocol. So that is in case you have got all three opacities that you're going to layer with. Now, let's talk about a case that is maybe not so complex. You're going to work with only two opacities. Like I said, different companies have different opacities across nomenclatures. So sometimes you may be layering with a dentine and an enamel, like now Coltine has started to do with Style Italiano. They don't use a body at all in the middle. Or you have a company like 3M, or you have a company like Kulzer, wherein they have got all three different opacities, and you use body and you use enamel. So it's very important for you all to find out what opacity it belongs to, and that the manufacturer is only going to tell you about that. So imagine now here we are using only two different opacities. So you're going to place the dentine or body, which is just flushing with the bevel, but it is not extending above the bevel. And you're going to place the enamel that is extending the bevel now. Now, what instrument is going to help us to prevent that glass effect is the anterior mesura that you see on the right. You see that instrument is running mesiodistally, such that on the bevel you're going to remove exactly 0.5 millimeter because of that step that they have kind of created. This will ensure that your thickness of the enamel is exactly zero point 0.5, preventing any kind of gray show through or underlying gray effect in the restoration. Okay, so which cases can we do with that? Simple cases wherein it's not open to the oral cavity. See what happens if it's a large restoration and the patient laughs or smiles, then you can really see the darkness of the oral cavity, and that's when your restoration starts to look gray. It is not when the patient is smiling, it is not when the patient is in occlusion, but it is when the patient opens and the darkness of the shadow, the darkness of the oral cavity kind of gives a shadow effect. So in this case, I'm using only two different opacities. And like I told you, I will take a picture. I will make it first monochromatic because value is, enamel is giving you value. So I have selected my, or verified rather, that my enamel is exactly fine. Then for the body, I'm going to give you an over chromatic image, and that's how you select the body. Okay, that determines the chroma. Now, this is something that is very important, rubber dam. So I hope, and I pray that, especially now that you all have become members of IAACD, everybody is using a rubber dam, because if you're not using a rubber dam, you cannot really bond. There is no escape from that. This is your basic crux. Okay. After that, you use an air abrasion unit. That is what I use is an aluminum oxide, which is 29 microns. And usually for my anterior teeth, I always total etch. Why? Because see, your nerve is quite away. Okay. And I'm not somebody who believes totally in the self etching protocol of the universal bonding agents. Nothing against them, but I find that those acidic monomers are very weak. They may act and they work beautifully on your dentine, but when it comes to enamel, and especially when we are talking about micromechanical retention, meaning your enamel being pitted, because of the action of the 37% phosphoric acid, for your resin to go inside and to form tags. I'm somebody who does not believe that merely using a universal agent with which is weakly acidic is going to really do it. So for my anterior teeth, I always do a total etch protocol, okay, which is I leave my etching agent for about 15 seconds onto my enamel, and if there is dentine kind of exposure, that is usually done in the posteriors, and I think about a selective edge, but anteriors mostly I'm going with a total edge protocol. So I get my frosted appearance that we all love. Okay, and then I've applied my bonding agent, I've got my glossy appearance, and I've made sure that I've blown air, either with a chip blower, or if you're using your airway three-way syringe from your chair, then you have to really ensure that there's no water coming out of it, there is no oil coming out of it, because you'll be surprised if you blow it on your glove how much of water actually comes out from it sometimes, and that can really weaken your hybrid layer. So that is one thing that you need to be very careful, and that's very important. I'm going to, where you see the two is where I'm going to put my universal or the body. Once I'm done doing that, like I told you, it should be just flush with your bevel. Like you see over here, the entire bit beyond the bevel, I'm going to then cover with my enamel shade, and that's how it looked immediately. But you should ideally always assess 7 days post op. Why? Because teeth, especially, and this is very, very important if you're taking shade selection. See, there's a saying in Style Italiano, shake hand and take shade. What that means is, immediately as your patient comes, you should determine, especially if it's a front tooth case, what is the shade. This cannot be done after prophylaxis, this cannot be done after taking a mouth retractors, taking beautiful photographs. The tooth starts dehydrating, and you can see a visible dehydration in the tooth at as early as 3 minutes and maximum at 45 minutes. So if you've selected a color or a shade at that point in time, when you finish your restoration, the patient comes back to you, your restoration is going to look more brighter as compared to this. In fact, when you finish your restoration should look a tad bit darker as compared to that of your tooth, because there is a change in the refractive index of the tooth when it dehydrates. So don't assess your shade at the end of the rubber dam procedure also thinking that, oh, I might have selected the wrong color. It is, the tooth is not actually giving you the right kind of shade or the color. You must only assess after 1 week, and then whatever changes are needed, you can go ahead and do that. Now let's go to La La Land and think that, okay, I can do my class 4 restoration by using only one opacity. Okay, but this is kind of happening now. We are trying to simplify protocols, and like I told you, we all of us are trying to move towards body. So if you read this book called Layers 2, they describe two techniques, that is called control body technique and a body screen technique, wherein you're using body at the end and you're not using any kind of enamel on top of it, and just by making some kind of changes in the surface texture, you can allow the scattering of light to happen in certain way that the tooth looks layered and it works beautifully. But it's just that you have not taken the pains of actually putting three different opacities or even two different opacity. You've managed with just one, but this is highly case specific. Now in this case, I've used a single shade and it is looking good. But if you look at the adjacent tooth, there's not much characterization that is happening, right? And like I told you, this is not swoon worthy. I mean, I'm not going to put this on Instagram and be like, oh my God, wow, those crack lines were exactly replicated or whatever. But this is functional, okay? Especially for a patient who does not want to spend 2 hours in the chair. If the patient has got 40 minutes, 45 minutes, respect that. Give a single shade restoration. He's going to be happy. Nobody is going to open his mouth, retract his lips, and say that, oh, wow, I love that translucency that has come. So you have to make restorations that are functional. Okay. Now, incisal effects and characterization. Like I told you, the young teeth have a lot of opalescence. You cannot give a mamelon effect in an old patient of 70 years old and say, I did a fabulous job. No, you didn't. Okay. So, on basis of that, you have to see the adjacent tooth and decide what kind of opalescence you want to give. And on basis of that, we have categorized teeth into 5 different types of opalescence. Three mamelons. The center mamelon divides into two. You can have multiple mamelon effect. You can also have a uniform incisal edge, or you can have proximal areas of opalescence. Okay, so you need to look at the adjacent tooth and you need to do the same thing for this particular tooth that you're building, and do age specific aesthetics. Now, when I look at these cases, sure, they look great. The first case, he had had a trauma. It was a swimming accident. He's a 12-year-old boy. So, of course, he's going to have all those mamelon effects, translucency, everything. We went for the full protocol. We went for all three layering opacities. But the patient on the right, she's a 22-year-old. She doesn't have any of that. She's got a completely straight edge, a flat incisal edge. So just imagine swapping this tooth in that dentition and that tooth in this dentition, how off it's going to look. So that's why I'm saying that you need to start looking at the tooth that is next to it, and you need to create them like twins. It's like Ram and Sham. You need to have static symmetry for both the central incisors. Lateral incisors and canines, if they start looking like each other's siblings with a little bit of dynamic symmetry, that's fine, that's acceptable. But for both the central incisors, it's very important that they look absolutely alike. Okay, so that's how he looks when he smiles. Now let's go in depth with one particular case. Here I have built my 1-1 and my 2-1. Okay, this is how I got him at a baseline situation. First picture that is taken, this is going to give you your U, but you're going to create two pictures out of this. Like I told you, a monochromatic, which will determine your enamel, and a oversaturated image that is going to determine your dentine. So now in this case, my recipe is OL, A2, and CL, what you see on the right. A1 is looking too bright for this. Okay. Again, I'm going to take this case. I'm going to remove whatever old composite restoration was there. Another advantage of using a rubber dam is if you can compare his gingiva. Look at the gingiva here. It's pretty inflamed, and here it looks like it's just there. Okay. So if I remove the entire restoration, I'm going to have a lot of bleeding there. How am I going to retract that? See where it's gone. So this is giving me ample of space. Plus, it, if you look at the 2-1 nasally, you will see there is some subgingival tartar, which I was not able to see before this. So now you can take your scaler and actually remove that, and it's not going to hamper your bonding protocol. Same thing, air abrasion, total edge protocol, frosted appearance. Okay, I'm ready for my bonding, glossy appearance. Again, patient was not in a rush, nor was I. So I got a nice wax up done, and I made a putty index out of it. Again, I'm going to scribe with my sharp instrument, and I'm going to build my palatal shell first. Now, this particular tooth does not have a lot of translucent effects, if you've seen the neighboring teeth. So I directly started building with my OL. And there is a technique called synchro matrix technique. What that means is that when I want to build two proximal walls next to each other, I use this technique wherein those posterior sectional matrices that you use for your class 2s. I'm going to use that, but in a vertical way, by inserting them into the sulcus and place a wedge in the middle in order to just stabilize it. But when I build I'm going to only build the proximal wall of one tooth. Still, I'm going to have the matrix on the other side so as to maintain the space. Otherwise, one tooth can look slightly bigger, one tooth can look a little bit narrower. We don't want that. But you build the proximal wall like you can see in number 3, one at a time. I've just built on the 1 1, and the 2 1 I build later on, and then I remove the sectional matrix after that. This tooth, if you look at the neighboring teeth, not now, but before I placed the rubber dam, it also had a lot of white striations and characterization. So I'm going to try and mimic that by using a tint that you saw here. And I've also created a halo. So I've placed a A1 dentine at the halo like a sausage. I've created like a sausage, like a long thread, and placed it over there. And on top of it, I've also placed a white opaque tint from Coltine. I cure everything. The last layer has to be cured under KY jelly in order to remove the oxygen inhibition zone. What that means is, see, when you cure composite, you may not be able to convert all of the monomer into polymer. This is a given. Everybody knows about this. So you have like a sticky film. Now, when you layer one composite layer on top of the other, the new monomers from here and the monomers which are active over here that have not formed the polymers, they bind to each other, and that is how one layer bonds to the other. But you don't want this in your top layer. Otherwise, you're going to have a discolored restoration. They may take up pigmentation from your food and all that. So how you're going to do this is you'll apply a layer of KY jelly. You're going to eliminate the oxygen inhibition zone so that you force the monomers which are available to form polymer chains internally again. And then, of course, you're going to do mechanical finishing and polishing. So that sticky film is going to go. But this is something that you should ideally do. And if you're curing your composite for one cycle of 20 seconds, then your top layer you should cure for ideally 2 cycles, that's 40 seconds. Okay. Now, finishing and polishing we are going to cover in the end, but the blue is where I am after build up, but I want to become the orange in terms of my transition line angle. Okay. So I have done my finishing and polishing protocol. This is just immediately the tooth is looking quite dehydrated. Okay. But look 7 days down the line. It's looking rehydrated. It's completely blending. You cannot even figure out where the restoration is, where the composite is, where the tooth is, where the critical zone is. It's all looking the same. Yeah. And that's just a comparison of pre and post. Now, in my opinion, shape is very, very important, even more important than shade. Like I told you, I don't believe that if it's an A2 and I made it slightly A1, it's a big, big problem. Yes, I worry about the value, but not so much about the chroma. I'm not that critical about it. But shape is something that I really, really worry about. And I'll show you why with this next case. So this patient comes to me. This patient came to me on a fly. He was flying to Amsterdam, and he requested me because he was the husband of a dentist. Yeah, usually their husbands are always in a rush, and the dentist was pushing me that no, please do it today only, we don't have the time, we cannot come back. So okay, we tried. So we did the BRB in this case. Of course, it's not super accurate. Again, I always start with the composite button technique. Like I told you, I always want to determine my enamels. I'm going to make a monochromatic. So in this, I've selected my value, which is on to the right side of the 2-1. I like that. That is blending better. Then I oversaturate the image. I like again the right one, which is blending better. So I have my dentine now. I have my enamel now also. And this is sort of the recipe which I kind of create in my mind. But for the sake of understanding, I have created like this kind of a blueprint for you today to understand that this has got like a mamelon pattern. The mamelons have got a little bit of tinting effect that is there. The halo is not very pronounced, and he's got a little bit of translucency over there. So this is my rough recipe that I have in mind, and I'm going to do this. Okay. So again, the same things, you're going to isolate, etch, you're going to bond. This is the end result after the BRB. Okay, I fell. I did not like it at all. I did not understand where I went wrong in terms of the shape. And that's when I decided that I have to redo this. Redo this, not in the sense that I'm going to remove all of this and redo it again. Redo this meaning for the first 24 hours, because your surface energy is still there, I'm going to just place my bonding agent and I'm going to make this longer and have better surface texture. The surface texture over here is pretty smooth. as compared to this tooth, which is not smooth at all. So this is what we created. And I liked this better, and so did he. So, what I'm trying to tell you is that though I have not altered the color, though I have not mimicked exactly those mamelons in amber, but still, this when I am at a talking distance from the patient, or I'm talking to a patient as a layman, I won't know any difference. And this is the immediate post op. He's not come back to me, but definitely it must be looking better on rehydration. Okay. Now, for people who do not believe that composites can last or survive, like in most lectures, I'm asked that, but how can it last? The crown is stronger. See, you need to understand it is not about what you replace the tooth with, it is important what you take away from the tooth. In case of composites, because you're creating only a bevel, you've not taken away a lot from the tooth. Okay. And though that's enamel and only is bonding onto that one edge, still it's going to hold on. This patient, she came to me as a 9-year-old child 12 years ago. Okay. And then she moved. She went to another country. This time when she was visiting, she had an ice popsicle and she happened to bite into it, because of which that piece kind of gave way, and that is why she's come back to see me. Is this 100% success after 12 years? I wouldn't say exactly, but this is 100% survival. And for her, in her mind, this is something which is chair side, this is repeatable, this is something that has worked for her for the last 12 years. And she is nice enough to admit that, okay, I did something because of which this restoration kind of chipped. Okay, she's nice enough to admit that. Most patients would come and say, Arey, wo nikal gaya, I don't know how it happened, but she was nice and she was honest enough to admit that. So we are going to choose composite again. The second thing I want you to understand in this case is the same image I have now oversaturated. Sometimes I oversaturate an image even when I'm not doing a composite button technique in order to appreciate the internal characteristics of the tooth. Now, just look at the tooth, which is virgin. You'll see a nice halo. You'll see translucency. You'll see there is not a clear mamelon pattern, which is like this, but it is more straight, the opalescence type 4. And if you know all of this, if you have all of this information in hand, you can then go ahead with your composite button technique, value chroma, like we've talked about it. You do your isolation, total etch. This in this case scenario, I created the palatal shell just with a flowable, and I created the halo just to see if I create the flowable in a higher thickness, what is the kind of effect I'm going to get. And I got a sizably good end result, okay, without me putting any kind of tint. Yeah. So this is my end result. Now, I want to talk to you very quickly about finishing and polishing, and this is my last pit stop, after which we can take some questions. Or else, if you want to see a video on finishing, polishing, we can do that also. We'll take a call on that. So, this is an absolute must book that I recommend that you do go buy and read. And this is going to explain in detail about a lot of things that I have spoken about, and I will also speak about finishing, polishing. Okay. Whenever you create a tooth, whenever you restore a tooth, not just you, even for me, the tooth may appear like a potato. Okay, you should not be afraid, you should not be scared. Now, what you're going to do, the finishing and polishing protocol is the heart of the restoration. That will determine how well the restoration now blends seamlessly into your entire dentition. So, you can take a restoration and you must now have a blueprint in your mind that, okay, I'm going to do this and I'm going to make the tooth look like the neighboring tooth with this particular way. So, for the ease of understanding, we always divide the tooth into these four steps. First, always recognize your outline form. Like in that particular case which I showed you, which I did with a BRB, I knew that I have gone completely wrong with the length of the incisal edge. So I've gone wrong with the outline form itself, so there's no point in me correcting the transition line angle. I need to start from zero only. Once I'm happy with the transition, with the incisal edge, and both the teeth are looking like, I would say, 75-80% alike, then I go to the next step, which is my primary anatomy. Once I'm happy with my primary anatomy, then I go for the secondary anatomy. After that, I go for the tertiary anatomy. What I'm trying to say is that it is a long procedure, so divide it into small steps so that it does not become overwhelming for you. So let's imagine that you have determined your outline silhouette now. What is step number one? That is for primary. There are two things. You need to determine where your transition line angles are sitting. Now, the good thing about transition line angle is that you have a reference which is in the adjacent tooth. You take that mechanical pencil, the very thin pencil, and you determine that you must create exactly that onto the tooth that you have built. You mark it in that. All the areas which are not in pencil are the areas you're going to touch. The pencil is going to stay. Okay. We want exactly the same kind of distance between the two transition line angle. And also, this is important in cases where you do diastema closures for you to create illusions. Okay. If you have a very wide space and you want the tooth to look narrow, then you can move the transition line angles towards each other and the tooth will start looking narrow. But if you want the tooth to look wide, then you can move the transition line angles away from each other and the tooth will start to look wide. This is the first thing you do. The second thing you do is that you start seeing the tooth with a bird's eye view, meaning you see incisally. Very often, whenever I see like our course participants and all also building up the teeth, they create like a dome. You know, they have the maximum bulk in the middle, in the body area, in the middle one third of the tooth, and their transition line angles are down. That is not how the tooth has to appear when you see it proximally. The body area or the middle one third, the tooth is actually flat, and your transition line angles are the areas which are actually projecting out. So that is very important. You divide the tooth like you do tooth preparation. You divide it into three different contours and curvatures. That's how you divide it into incisal, middle, and cervical. And you will take your burr or you will take your disc also in that particular way. So now you finished your primary anatomy. This is what you need to finish in primary anatomy: your transition line angles and your three different curvatures. Okay. Now you move on to your secondary anatomy. Of course, knowing that your adjacent tooth has it. If your adjacent tooth does not have it, don't go ahead and do it. Now imagine that you divide the tooth into a half. Okay. There are two Eiffel towers that are present. Now I used to do this early on in my career. I used to use a TR13F and I used to try and create that groove, but my burr used to always slip because it is at a high speed. So what I've started doing also now is I take a round burr which is really small, I put it into a burr converter and I use it with my micromotor, because at low speed you don't have to use water, so you can actually see what you're doing. And you need to also understand that you are actually doing finishing and polishing for composite at an interface with the tooth. Now tooth has got a different kind of hardness, your composite has got a different kind of hardness. If you use the same kind of abrasives for both the surfaces, there is a very high chance that the composite is going to abrade faster and your tooth structure is going to be slower. So you're going to have a step. And that's when you expose your demarcation line. So many a times people tell me that जब layer किया था we did not see the demarcation line, लेकिन finishing polishing करने के बाद the demarcation line started to show up. That is because you were very overzealous with the finishing polishing protocol. So when you're doing finishing, you can avoid water provided you are at low speed, but you need to visualize, you need to see where you're kind of going. So first I use my round burr, and in that particular groove only, then I start using my 13F tapered fissure burr, and I go to the left and I go to the right, creating that kind of a anatomy. Okay, so this is how it will look after you finish your secondary anatomy. Now, for tertiary anatomy, you need to be cautious. Word to the wise is that tertiary anatomy should be created, or a rough kind of pattern should be created only and only if it's a very young patient and you think that you just can't make do without it. Because when you try to create these horizontal textures, which actually translate to perikymata with the burr, they can also act as plaque retaining areas. So you need to be very careful that your patient is going to maintain oral hygiene before you create these kind of rough textures. And if you want a very rough texture, then you can use the tip of the burr. If you want a very like a fluid pattern and something that is not very aggressive, then you can use the body of the burr also. Again, I use it at slow speed with a burr converter in my micromotor because I get a lot of control over that. If you have an electric handpiece, great, do use that. Okay. Now, this is the end result that I see. So this is my entire protocol of what I use. So I use a TR13F. The BR40 is the round burr. Then FO25 is for my palatal areas, whatever excesses are there, and for adjusting my occlusion. This is optional in case you want to use the SSY 10, 20, 30. I no longer use it. I use some stones which are green and white from Shofu. I use some silicone points. Discs I majorly use from 3M only. I find good control on them. And see, with discs and everything, because you're not using water, but you do need to clean that powder which is sort of generated in between of these finishing polishing protocols. So you can use like a wet gauze. I'm usually at a speed of 10 to 12,000 RPM. And when you use their 3M polishers, which are those discs, the diamond impregnated ones, that is around 15,000 RPM, but that you can use water with. Okay. And for diamond polishing paste, I usually use Lucida, which is from Style Italiano. That you can use with its felt. They in that entire kit you have a felt buff which is about 2 millimeters, and you can use that at a speed of about 5,000 RPM. And then when you want to increase the speed, that time you can use a little bit of water with it. So this is my entire protocol. Now, this is the end of my lecture. Depending on what you all want to do, if you all want to take Q&A, then I won't be able to show you a video which is for finishing polishing, because that is about a 6 minutes video. And if you want to watch that, then we can take a Q&A. So you guys decide. I'm going to come out of this. And this is from one of my very famous, very favorite authors from Manifest Now, that you need to decide for yourself. A lot of times people say that, do we need to be really so aggressive when it comes to getting your goals and targets? I think you should. That I just come from a different thought process, and I feel that you need to have goals and you need to have targets. Now, today, if you've attended this lecture, you need to have a goal for yourself. 3 months down the line, what is your plan? How are you planning to improve? 6 months down the line, what do you see yourself doing? A year from now, what do you see yourself doing? And have these little targets, little goals. That's going to help you get better. Okay, and there is, I think, no upper roof if you start thinking that way. I mean, the sky is the limit for you if you start thinking that way and give yourselves little goals. That's me. If anytime you want to reach out to me, we also do 2 and 3 days small workshops with very few participants to ensure that there's a lot of one-on-one interaction. If in case you all are interested, you all can reach out to that. Or with IAACD, we are always there. We are going to be there at the annual conference. I'm going to come out of this, right, Harsh? We want everybody to attend that, right?
Oh, absolutely. I'll never say no.
So
Well, yes,
depends
go on.
on what people want to do. We can either take Q&A or we can see that video on finishing polishing. You guys tell me.
Okay, firstly, Sana, thank you so much for such a fantastic presentation. You explained the nuances of this class 4 composite built up very well. I'm sure all of us have picked up a few pointers which we can incorporate in our practice. We do have a few questions for you. So in the end, if we have some time, then we'll incorporate the video.
Sure.
Okay. The
Sana, you
first
can put
question
your
is,
screen share off.
I'll stop
We
sharing
can
this.
see a lot of ourselves.
We are
okay,
self-obsessed, no? But
okay. The first question is the bevel placed only on the labial, or do you advocate bevel on the palatal aspect as well? Is the bevel only for masking the junction of the tooth to the composite?
so bevel is only placed on the buccal. Palatal, there's no need at all. See, we are not doing this for bonding. Okay, if you are trying to ask me whether we need to remove the unsupported enamel, that is a different thing altogether. Bevel is only for aesthetic concerns. You are going to place the bevel only buccally because you want the demarcation line to not show. If you don't have unsupported enamel in your palatal, you don't need to place any kind of bevel. That's a completely different thing.
Okay. The other question is opaque shade the dentine shade? How much should be the thickness of the opaque shade? Please recommend one or two good brands for the opaque shade.
So see, it depends on what company you're using. If you're using 3M, they have four different opacities. They have an opaque, they have a dentine, they have a body, they have an enamel. If you're using something from Kulzer, then they don't really have an opaque. So you go back to your manufacturer. It is not an absolute must for you to have an opaque. Like for the last 5 years in my practice, I don't have any opaque shade. Because see, opaque, even if you need to place it, the minimum thickness you need to place it is 0.5, and that you're going to prepare the tooth only for, right? Like I said, you need to take a balance. What are you taking away from the tooth? It is not important what you're giving the tooth. So in thin sections, how can you work? Then in such cases, you have these nice pink tints which are available from Dental also, which if you have a highly discolored tooth or you have tetracycline stains, it's like a nice baby pink color. You can place that and directly start off with your dentine and then your body and your enamel, or even end at body. That gives you a beautiful result as well. Like if I have started doing a lot of composite veneers, and earlier I used to go the entire protocol, and that used to take me like 4 hours, 5 hours to do six teeth, eight teeth. Now I've started doing only body, and I can finish six teeth in say 2.5 hours, start to end. So we need to decide how much time can we spend. It also depends on how much you're charging the patient, because to be very frank and open, you're working in India, the amount of money that you're going to charge for an indirect restoration is definitely going to be more as compared to what you're going to charge with a direct restoration. Because patient ko end of the day यही लगता है कि your work has not gone to the lab. How do you justify charging so much? So there's definitely going to be that kind of discrepancy. If you are able to charge that much while spending so much of time, go ahead and do it. But in my practice, generally, I've seen my patients will be ready to spend 15, 18,000 rupees over a crown. But if I tell them that I'm doing this build up and I'm using all three opacities and you pay me 20,000 rupees, that's not happening. That's not happening.
Okay, the next question is, could you elaborate on finishing the bevel or the interface line in case of an anterior class 3 or class 4 case before actually beginning the restoration?
So class 3 follows a very different protocol as compared to class 4. Class 3, if you have a very small class 3 and it is not crossing your transition line angle, you don't need to place a bevel. You just don't need to. Why? Because at that interface, imagine your transition line angle is going proximally inside towards your contact area, right? So that is an area which is already receding. So if it is not crossing the transition line angle, you don't need to place a bevel. If it crosses the transition line angle and it is just about crossing, then even a short bevel of about 1 millimeter works. If it is a very big restoration, like you feel the tooth is looking like an eaten apple, that happens sometimes with class 3, which is mesial as well as distal, then in that case you have to place a proper medium bevel which is 45 degrees and it is 2 millimeters from that edge of your cavity. So that is about your class 3. Class 4, like I said, small, medium, and your large bevel. Small bevel only in the case of small chips which are present incisally. Medium bevel, most of the cases. Maximum cases will be 2 millimeters, 45 degrees. Of course, converted to an infinity bevel because, at the end of the day, you don't know and I don't know where I'm going to finish that composite. Nobody knows. I mean, you're just using a modeling resin and you're using a brush. So in very thin sections, it's a possibility that your composite is going to land up even 3 millimeters away from the fracture line, but you've prepared only 2 millimeters. So you need to do that protocol. And large bevel, like I said, I don't generally do that at all. I haven't done one in a while. If you have a tooth which you're going to do a direct veneering on, then you don't really need to, in all practical purposes, place a bevel. You're going to cover the entire tooth. So that works. That's fine.
Okay, the next question is, while selecting composites, how much importance would you place on adaptability
I would place a
of
lot
the
of
composite?
importance to adaptability. See, it's very important that you're comfortable with the texture of the composite you're working on. And I'm going to give you examples in this. Like 3M, for example, when if you all have worked with 3M, it has got a very creamy kind of consistency. Okay, that has also got to do with the fact that they have certain kinds of fillers in them and they use certain kinds of nanoparticles in clusters and all of that, and as opposed to another company which is like maybe Kulzer Topaz or maybe an Ivoclar which is highly filled. The more filler content there is in a composite, the more rigid it will be, because then the workability of the material is less. Now I've had both schools of thought. I've had certain clinicians telling me, but no, I prefer the rigid composite. If you work with rigid composite for layering, especially on anterior teeth, in my opinion, you need to work with a brush and a modeling resin. There is no getting away from that. But if you have a more pliable composite like 3M, maybe you can get away without using a modeling resin because the material itself kind of flows. So there are both of these possibilities. But I generally say that if you're layering quite a bit, then make sure that your overhead light or the loops light is on minimum. so that you're not going to inadvertently set that composite. Use a brush. You have beautiful brushes available from Tokuyama. They are both ended, like they've got a sharp end on one side and they've got a flat end on the other, and use some kind of a nice modeling resin with it, and that will make your life really simple.
Okay, the next question is, once you have a patient with a fractured tooth, would you advise that we take a radiograph and also check for any exposure at the same time?
See, in the case of anteriors, it's pretty clear cut, in my opinion. Either you see the nerve or not. Even in posteriors, now we have started to do that in order to avoid having an exposure. In fact, provided your peripheral area is devoid of any kind of decay or any problems, and you have that seal that you can create in the middle, even if you have a little bit of a decayed area or an area which is close to the nerve, still you can get away with it, in my opinion. For as long as possible, maintain the vitality of the tooth. There's no coming back from that. There's just not.
Okay, the next question is, the shades we need to keep in our clinic for layering techniques, enamel, body, and dentine shades.
So it depends now which company they are going to go in for, but at least body shades of A2, A1, and A3, I would recommend. Now, company wise, I can't, nobody's paying me to say anything. So it all depends on you all, what you all want. But I would say that pick up a nano composite, a nano hybrid, in my opinion, you should go for. Get a decent dentine. Opaque, like I said, I don't really think that it is important. Even if you get an A2 dentine, it can work with A1 in a body also, it can work with A2 body also. It works. And enamel wise, if you're going for something like 3M, then A3 enamel works in most cases. And get a CT and A3 enamel for enamel. Body, all three you should ideally buy. And maybe an A2 dentine. This would be the least armamentarium that one should go for, I feel.
Okay. In the finishing and polishing step, do you suggest doing both in the same sitting or a gap of 1 day? Also, do you move the disc from the composite to the tooth side, or is it vice versa?
No, this is a great question. See, you can do gross finishing and polishing on day one. And when you recall the patient after 7 days, you can do finishing, polishing again. I don't recommend doing it the next day because, like I said, the tooth has not rehydrated. So if it is, depends on how much chair side time also you have. Now if you've done a case of smile designing and you've done 6 teeth, 8 teeth, definitely you're not going to have any kind of wind left in you to actually do the entire protocol of finishing, polishing. So go for the gross finishing, polishing. You can always recall the patient after 7 days of rehydration. One is that. Second is, you always finish and polish from the composite to the tooth, because like I said, both of them have got very different kinds of hardness. So if I'm using an abrasive, like for example, I'm using a disc which is the most coarse, it may not work so much on the tooth, but it will work beautifully on the composite and you may remove too much. So finishing has to be done without water, low speed, lowest speed, in fact, so that you even get tactile sensation. And then for polishing, you can go with a little faster speed in staccato movement, like in a movement where you're just touching and kind of moving away from the tooth. That is fine, but always from composite to tooth. Even blending is composite from tooth, not from tooth to composite. When you're putting the composite.
Okay, the next question is opaque shade the dentine shade?
No, not always. So the cases that I showed you, like the video that I showed you, there the opaque light is the dentine, that is in Kulza. But if you go for some other brand, then they are opaque and their dentine could be different. So you need to reach out to the manufacturer and actually ask them what is available. If across different companies, things could be different.
Okay, our last question for the day is, universal composites available in a composite kit, are they enamel or are they in body shades?
Universal is always body. Universal is always going to be body. Enamel, they are going to write an E. Mostly they do.
Okay, thank you, Sanah. Thank you so much for the wonderful presentation and answering all our questions. Thank you so much, everyone, for joining and giving your time and staying tuned with IAACD. Now, a better way of attending such informative sessions is by becoming a member. To become a member, go to iaacd.com and click Join IAACD. So looking forward to seeing everyone in many more such informative sessions. Good night and have a fantastic evening.
Thank you. Thank you for having me.
Thanks,
Guys, we're
Sana.
really looking forward
Thank
to
you so
having
much,
you all in
Sana.
November. Please join us.
Yes.
Thank you. Good night. Bye,
Thank you.
everyone.
Bye. Thank you.